Okay, thank you very much for the introduction and for the invitation to speak today about the role of the surgeon in the TAVI team. I apologize I wasn't able to join you there today in beautiful Athens. These are my disclosures. My hospital receives fees from these different companies on my behalf. So this may be some of the view of some cardiologists is that cardiac surgery is on the way to extinction with the ever expanding indications for transcatheter valve and coronary artery disease treatment. But I hope I can convince you today that I have a different perspective. This slide you've seen many, many times. This is the isolated aortic valve environment in Germany over the last 15 years. And of course, you note the very rapid expansion in the number of TAVI procedures over the last few years, and a steady decline in the number of SAVR procedures since 2014. But if you look at 2022, you'll see there was actually more SAVR procedures performed than in 2021. And in 2023, I've seen the data, but it's not yet published. There was even more SAVR procedures being performed. So maybe we've reached, at least in Germany, sort of the equalization point, and this will probably stay this way until we get more data that suggests that the needle should move in one direction or the other. You are all very well aware of the market advancements that have taken place within the TAVI platforms over the last few years, starting with high-risk trials and then progressing to intermediate risk, and then finally the low-risk trials, where we recently had the 5 and 4 year outcomes presented for Partner 3 and Evolut low risk. We also have even longer follow-up for the Notion low-risk trial, although it's important to note that for Notion, the average age was 79. It's also important to note that for all 3 of the low-risk trials that we currently have longer-term data on, Evolut, Partner, and Notion, that bicuspid aortic valve patients were an exclusion criteria. Over this evolution, we've seen progressively less paravalvular leaks, less prosthesis patient mismatch, especially for the self-expanding valves, decreasing pacemaker implantation rates, decreasing access site complications, and a couple of randomized trials have shown that anticoagulation can be simplified down to simply aspirin, a daily aspirin dose. And all of these very positive developments have led to this market increase in the TAVI procedures that I previously showed. But we are in a bit of a political question here, and does the surgeon need to participate in the TAVI heart team? In other words, the heart team, is this a catchword, or is it actually being performed at the individual sites? And here's a recent figure that I downloaded from the AHA website. And I was very surprised to see interventional cardiologist or a cardiac thoracic surgeon would be talking to you about your aortic stenosis. At least in Germany, it's legally mandated that both of these specialties are present when discussing optimal treatment strategies for the aortic stenosis patient. So I was quite surprised to see this in the United States. If we look back historically, we performed the first successful transapical TAVI in the world here in Leipzig. Tommy Walter and Fred Moore, together with Michael Mack, back in 2006. And back then there was a lot of complications, not just the transapical, but also the transfemoral patients, mostly because of the large sheath diameters, necessitating firstly surgical cut down. We even used cardiopulmonary bypass routinely for the first few patients. And there was a relatively high complication rate that required surgical bailout. Several such examples you just saw Raj Makkar show in his presentation. But we felt that the heart team, which was based on the syntax experience for which Fred Moore, my predecessor here, was the surgical co-chair, that this would also apply well to patients with aortic stenosis. And this concept became increasingly popular over the several following years. And as a matter of fact, in the last version of the heart valve guidelines, the word heart team is mentioned dozens of times. In Leipzig, we do live the heart team concept. It's not just a catchphrase for us. On the top left is Thilo Noack. He's our surgeon, who is the co-director of the structural heart team in conjunction with Mohammed Abdul Wahab. I'm sure many of you know him. Mohammed is a really gifted interventional cardiologist. And I would say that the surgical input here is very important for the reasons I'll show in just a few minutes. But this was originally Fred Moore's idea, is that the surgeons need to be actively involved. They can't just be sitting in the back corner fetching coffee and cream for the other members of the team. That such a role does not make one an active member of the heart team. And one of the ways to overcome that is to make sure that there's a common budget. So financial incentives are removed from the teamwork environment. And that's certainly what we have here. But here's an example of why I strongly believe that it's important to have representation from surgeons in this decision-making process. As you know, in the European valve guidelines in 2021, it was suggested that patients less than 75 years of age should have SAVR as the procedure of choice unless there's a contraindication, and those older than 75, TAVI should be the first procedure to be thought of, whereas the American guidelines were more nuanced, saying less than 65, by default, the patient should get SAVR, and more than 80, patients should get TAVI, and in between, there should be a heart team discussion. However, in the United States, those guidelines that were published in 2021, there's been an explosion of TAVI procedures since then. And even though the guidelines very clearly state that SAVR is the procedure of choice under 65 years of age, you see from this publication 2 years ago that almost half of all patients under 65 in the United States are getting a TAVR instead of a SAVR. So this completely contraindicates or contradicts guidelines. And the question is why? And what we can do to try to encourage people to follow guidelines. And here's where I see the surgeon playing the most important role in the heart team. The surgeon is part of a very complex process, including the clinical and imaging assessment, and the heart team evaluation of the patient, of course, also discussions with the patients regarding their goals and preferences. And in this review article that Stefan Windecker and Volkmar Falk from European Heart Journal, they outlined the different steps that are complex, multifaceted, and can benefit from input from many different points of view, including from the surgeon. And they said that the heart team is strongly recommended for achieving optimal patient outcomes. And this is also written in the valve guidelines. So here's a picture from our heart team in the pandemic. It's actually bigger now. We meet every day at 3:30 p.m. There is not only an interventional cardiologist and surgeon, but also radiologists, non-interventional cardiologists, anesthetists, et cetera, so that they can incorporate these complex decision-making processes like you see in the right side of the table, which was in this review paper. And here's a typical day in our center. You can see in 2 hybrid rooms, we have 8 transcatheter valve procedures done. This is not a big exception. Anybody who has been to our center knows that this is what happens every day, and we're finished by 3 p.m., 8 cases. I think we have the largest TAVI program in the world. So it's not like we are people actively working against TAVI by any means, but we strongly believe that the guidelines are there for a reason. So on the left, you see the average TAVI age, as well as the Fox plot distribution at our center over the last 15 years. And you see the average age was 82 in 2006. And in 2023, the average age is 81. So we strongly believe in the heart team concept, even though we are treating more and more lower risk patients that are elderly. Without a doubt, I strongly believe elderly patients, low risk, they should be getting TAVI rather than SAVR because they can get up and around much faster. The question is what to do with the younger, lower risk patients. And there's food for thought out there. This is one paper last year, which is a meta-analysis of reconstructed time to event data for all of the randomized trials for SAVR versus TAVI. And when you pool together all of the different trials, starting at 2 years after the procedure, there is a statistically significant advantage of surgery, and this is for all-cause mortality. This is not pacemakers or paravalvular leaks. This is all-cause mortality, suggesting that in younger, lower-risk patients, SAVR should be strongly considered. And these authors found a 25% higher hazard ratio for death and stroke after 24 months. So we have to take these facts into consideration. Here's another interesting slide comparing the recently published long-term mortality up to 8 years or survival in isolated SAVR from the STS database compared to the SAVR patients from the low-risk randomized trials. And the survival in the real-world all-comers STS database is higher than in the surgical arm of the randomized trials. There's several reasons for this, including patient selection bias in the United States. That is, the patients that are now getting SAVR in the US, because of the slide that I showed you before, are very low risk. But there's definitely a bit of a misconnect between those real-world data and the SAVR data from ongoing trials. So who are these low-risk and younger patients? Well, of course, they're mostly the bicuspid aortic valve patients. And as this case shows here, these can be very, very dangerous valves for TAVR. For us, for SAVR, it really doesn't play a role. Nobody ever even thought to compare bicuspid to tricuspid aortic valve stenosis patients for SAVR in the past because we never, ever, ever saw that it really made a difference for us until this became an issue within the TAVI literature. So this is such a patient with this massive calcium, with this the horn of, now I've forgotten the word now in English. My English gets worse and worse ever since I've moved to Germany. But this calcified raphe that can puncture into the muscular septum during balloon expansion and can lead to a life-threatening annular rupture. An annular rupture in the fibrous portion of the left ventricular outflow tract, we can fix that as surgeons. An annular rupture into the muscular portion is almost uniformly lethal. And there's also coronary anomalies as well. Paravalvular leak rates, this is a meta-analysis, we know occur more frequently in TAVI bicuspid patients compared to tricuspid patients, TAVI patients. Conversion to surgery also occurs more frequently in bicuspid aortic valve patients than in tricuspid aortic valve patients receiving a TAVI. And device success rates are lower in bicuspid aortic valve than in tricuspid aortic valve TAVI patients. So we have to be a bit careful before we start applying these procedures in younger and lower risk patients. Also because of this reason, a meta-analysis of 10 studies, including 1,600 patients post-TAVI who got a SAVR, the STS predicted risk of mortality rate was high. These were 8.1% is a high-risk population. But when you look at the results are terrible. Half of the patients required concomitant surgery, including aortic repair, which is particularly common after self-expanding valves. And the 30% mortality was actually twice the STS predicted risk of mortality. There is no other operation we do as surgeons that has a higher risk than the STS predicted by twofold. No other operation. and there was no demonstrable interaction effect for endocarditis. So this was independent of endocarditis. So this is something we have to think of before we start routinely applying TAVI in patients under 65 years of age, especially if they're bicuspid. And the final reason I would say that a surgeon still needs to be involved in the TAVI team are the two papers I will present now. One was just recently accepted in JAHA, and that is this multi-center study from several German centers starting 2009 to 2001. You see that conversion to sternotomy, emergency sternotomy in the operating room, so during the TAVI procedure, is an uncommon event. It's only 0.5%, so that's fantastic. We also excluded those patients that had non-transfemoral access, or those patients that we felt were critical, sort of being done as a last chance, either with shock or after resuscitation or mechanically ventilated. So we ended up with 152 patients who, to everybody's surprise, all of a sudden required an emergency conversion. You would see that these are high-risk patients. They're 80 years of age. Sorry, they have multiple morbidities and tend to be high risk. 63% were high risk, 19% intermediate, and 17% were low risk. Frailty in over half of the patients and multiple other comorbidities, as you can see here. So what happened with these 152 patients? They had to have their sternum opened because of mostly tamponade. These are not mutually exclusive, these indications. But annular rupture also occurred not infrequently, or valve dislocation, and left ventricular perforation also not too infrequently, whereas coronary obstruction tended to be more uncommon. And these were the different surgical techniques that were necessary: aortic valve replacement or complete root replacement Bentall, some sort of repair of the aorta or replacement of the aorta. Sometimes a root enlargement was required, or even an arch replacement, or bypass surgery for those patients with coronary problems, rarely mitral or LVOT patch repair. And the cross-clamp times and cardiopulmonary bypass times were not that long, and 9% of patients did not survive the procedure that were low risk versus 13% which were high risk. And this was one of the arguments in Germany, at least in the initial phases of TAVI, is they said, well, why do we need to have cardiac surgery on site? Anybody who requires immediate cardiac surgery during a TAVI procedure dies anyways. Not true, as you see from this slide. And in-hospital mortality, although much higher, was also, at least for the low to intermediate risk patients, somewhat acceptable at approximately 1/3. And when we looked at their 1-year survival, the low intermediate risk patients that survived the hospital during landmark analysis actually had a very good prognosis. So 94% of those patients were still alive 1 year if they survived the first 30 days. And this is another paper that we've already published in EJCTS, just based on our own experience in Leipzig. 7,000 transfemoral patients, 1.1% needed to be converted, more frequently during the early years of the study, 2006 to 2010, compared to the most recent 2016 to 2020. The vast majority never required conversion, but like I said, 74 did, 1%. And we found in-hospital mortality and 1-year mortality very respectable, 12.5% for the low to intermediate risk. So as we expand the indications for TAVI and we start doing these procedures in lower risk and younger patients, it's even more important to have a surgeon immediately available in case a disaster occurs. And here's the 1-year survival curve for low intermediate risk versus high risk. So in summary, market progress continues to be made in TAVI technology and outcomes, leading to increased TAVI implantation rates. And the most recent low-risk studies are encouraging, but we need to remember that these studies, first of all, excluded all bicuspid patients, and secondly, the average age was 74 for Evolut and Sapien, Partner, and 79 for Notion. This is miles away from what's happening right now, at least in the United States. And from my point of view, surgeons remain an integral part because of the knowledge exchange that they can contribute to, and also for backup of emergencies, especially in younger and lower risk patients. Thank you very much for your attention.
Thank you very much, Professor Borger. I think you convinced us that how extremely important the role of cardiac surgeons are during the process of patient selection and management for TAVI patients. Regarding patient prosthesis mismatch, I would like to ask you a question. Since we seem to go to lower age groups for TAVI, how do you manage, how do you discuss in your heart team the possibility of avoiding this phenomenon of patient prosthesis mismatch with TAVI? Do you discuss what options there are for the patient regarding transcatheter versus surgical procedure?
Yeah, it plays a role in our discussions. Obviously, if the patient is at risk of patient prosthesis mismatch and we're going to do a TAVI, then we use a self-expanding and not a balloon expandable. Having said that, the self-expanding valves, there is some data suggesting that SAVR post-TAVI in those valves is particularly bad, the outcomes, which also makes sense for anatomic reasons. And therefore, you have to keep that in mind if the patient is young enough that they may need a SAVR in the future. There's also the issues of coronary access as well after a self-expanding valve. We don't forget also that for surgery, there are options and there's increasing use of annular enlargement. And even sometimes for really extreme cases with a very small annulus and small root, we do a full root replacement with a special technique that the valve is sitting outside of the heart afterwards in order to really maximize the size of the implanted SAVR valve. Those are all things that we take into consideration.
Thank you. Are there any comments from Dr. Ioannou?
Thank you for the information of a well and especially organized center. I would like to ask you, do you think that the difference in the distance from the guidelines is related with the cost of the operations?
So the disconnect between the guidelines and what's currently happening in the United States, well, I don't want to speculate too much. I don't practice in the United States anymore, but there's obviously some pressure being put on in those environments on the cardiologists and on the surgeons for whatever reason to not be following the guidelines. Financial pressure to me makes the most sense, but I can only speculate. I'm surprised that the funding agencies aren't going after this because to me it's a blatant transgression, so to say, and there's a lot of money that I'm sure the insurance companies and the state would be saving if they started trying to enforce or at least trying to get people more in line with the guidelines. But thus far, I haven't heard anything. It's surprising. I'm watching it from afar with a lot of interest, especially as the co-chair of the next set of European guidelines for valve disease.
Please. Comment?
Dr. Borger, congratulations for your excellent presentation. And our heart team is in agreement with your team more or less, and we participate in difficult decision making if we need to take alternative accesses. And of course, everything is done for the better outcome of the patient. But I have the feeling, as you mentioned at the end, that the industry, different associations push everything towards the TAVI procedure, despite the guidelines about the lower risk patients. And of course, I would like to ask our colleagues from USA how they accept a patient under 65 years old to half of them to treat it by TAVI, despite the recommendation and the guidelines recommend against that. And this is not very
It's a great question, and I would like to ask my American colleagues that as well. I don't know the answer to that, especially with the legal environment in the U.S. is a lot more punishing than it is in Europe, a lot more.
Take the microphone, please.
Mike Reardon, how are you? Great talk. So I'll answer from the U.S. perspective. I think the problem, Michael, is severalfold. First of all, a very distinct minority of cardiologists or cardiac surgeons can really tell you what their low-risk trials did, who they tested, and what the outcomes were. You start asking cardiologists or surgeons how many people were less than 65 in these trials, they can't tell you. How many were less than 70? They can't tell you. Outside of bicuspid valves, they can't tell you who was and wasn't treated. And then all these people, of course, were approved locally, and then they go to a national screening committee, and as you remember, one trial, over a third were turned down there, and the other one, 15% were turned down. So they clearly are not all-comer trials. These were very selected patients because they were protocolized, and then they were further selected. And then you get down to sites that may do 50 cases a year, which is the majority of the sites in the U.S., and there's no surgeon that's really even part of the heart team. And so it's really sad, Michael. I think in the U.S. the problem is non-existence or dysfunction of heart teams in the majority of sites.
So I agree with you totally, Mike, and therefore I'm very happy that the organizers here asked me to speak about this topic today, and this is something that we just have to keep talking about.
I think in the U.S., we've written several articles about this, about who wasn't treated, and I think that fortunately we're starting to see this come into the AA test this year, had some structural stuff. I think surgeons need to be better educated so they're not afraid to come into the heart team and voice their opinion, but they need to know the data.
Couldn't agree more.
But a great talk, Michael. Your place does super work.
Thank you.
Thank you. I would like to ask Dr. Dardas and then Dr. Kilic for a comment.
Hello. Congratulations. That was a really excellent talk and put things into a very clear perspective regarding the cooperation between interventionalists and surgeons, and I really enjoyed it. I would like to ask two questions. The first question is, do you pre-plan or pre-select your surgical valve with the mind of this patient may need a TAVI procedure in the future? And do you have any special recommendation? What surgical valve would you put? And the second question is, if you have a, say, 70 years old male with very good anatomical features, everything is clear cut, and he can either receive a very good TAVI or either receive a surgical valve, would you recommend on this patient to have a surgical valve or to have a TAVI, say, a Resilia, which they claim that it lasts longer? What would be your opinion on that?
Great question. So for younger patients, especially those with a small annulus, yes, we will use the Inspiris valve in order to facilitate a future valve-in-valve procedure. For patients with a larger annulus or patients that are a bit older, we like the Avalus valve for financial reasons. I work in a center that's owned by a private company, so we always have to be thinking of financial aspects as well. And your second question regarding the 70-year-old who's otherwise healthy, I would definitely suggest a SAVR for that patient, because the reasons that I said before, SAVR post-TAVI results are a catastrophe. We don't know what we're doing with that operation. We have to get better at it. It's the fastest growing operation in the United States, but we need to understand why those patients do so poorly. And TAVI post-TAVI is also not nearly as good as first-time TAVI. So you're basically a 70-year-old who's really healthy. You're expecting that person to have a reasonable chance of outliving the valve, and then you're sort of committing that person to a less optimal solution when they're 80 or 85 years old. And doing a SAVR at 80 or 85, and we do them all the time here post-TAVI for endocarditis or for failed TAVIs because we put in so many TAVIs, you're not doing the patients any favors. I would suggest SAVR first and then plan that patient for a TAVI valve-in-valve later.
Okay, thank you very much.
I
would agree with you.
Thank you. Last question from Dr. Kilic.
Questions? Dr. Borger, first of all, congratulations for your speech. But when we look at the comparison of the TAVI trials and the surgical trials, especially in meta-analysis, we should never also forget that some of the transapical patients were also in that meta-analysis. So as we know that TAVI is superior if transfemoral done. So this is very important point. And the second point that you mentioned in your Leipzig experience, I showed that there are a lot of, for example, ventricle rupture during the conversion to the TAVI, to the surgery. So really, we believe that in our institute as a heart team approach, but especially some of the risk scores, when we look at to the SDS, also the Euroscore, in some patients, some indexes are not present in that risk scores, like liver cirrhosis, especially in young patients, previous radiotherapy, and also the emergent valves are also coming from the TAVI perspective. So I think we should look at not only in one eye, but with two-eye perspective for evaluating all the trials.
I would like to respond to you with two eyes, okay? Liver cirrhosis and severe radiation-induced mediastinal changes, we're talking about less than 1% of patients. We're talking about 0.1%, okay? So that, you can't say that that's a common reason for TAVI. That's just not true. Regarding your first comment that the meta-analysis include transapicals, that is true, but also this is a very small minority of the patients. At our center right now, we do about 1% transapical. And you also said TAVI is superior to SAVR. It's not. I'm sorry, it's not. And this is the sort of miseducation that so many people have. Those trials did not show superiority. They showed non-inferiority, or the superiority that they did show was in safety outcomes at 1 year. So if you're talking about a 60-year-old, I don't think we should only be worried about their 1 year outcomes. We need to be thinking about what happens later on. And as for comparison of any transcatheter to surgical procedure, there's worse outcomes for surgery because it's much more invasive. But the effectiveness tends to be better, and that's why the curves start to cross over time, which they did for partner 2, which they've come together for partner 3 for Evolut low risk. They haven't yet crossed, but I'm suspecting that they probably will, but it's just speculation. So please don't say TAVI is superior to SAVR. That's just not true.
There are a lot of points to be discussed, maybe ongoing. Maybe Dr. Reardon, maybe you can give some examples from the...
I'm a healthy 71-year-old. I'm going to pick my surgeon properly. The big mistake people make for young people is picking the wrong surgeon and getting a bad valve. But you know, you get the right valve, you'll do very, very well. You operated me, Michael, I'll be out of the hospital in 4 days, and asking when I can go back to work. I'm going to see you when I come to Leipzig, though, not one of those other guys.
Hopefully you don't need surgery.
Yeah, I hope not.
Thank you very much.
Thank you. Thanks very much.